Hi, Renee. Welcome to the podcast. I'm so excited to have you on.
Thank you. Good morning. Good
Good morning.
afternoon.
I know. You guys, I'm so excited today because I have one of my best friends, and she is a labor and delivery nurse. So she's going to give some great advice for all of the moms that are going through pregnancy and preparing to have a baby. She's had so much experience. She's been a labor and delivery nurse for 6 years, right? Now,
Yes, cheers.
easy. In Denver, Colorado, and she is such an amazing, human being, but also just I know I would absolutely love to have her as my labor and delivery nurse. I'm sad that I can't, but she basically acts as that when I'm in labor anyways. So yeah, so maybe you can just introduce yourself a little bit and talk about what made you become a labor and delivery nurse, and we can kind of jump into some questions.
Great. So I've been a labor and delivery nurse here in Colorado for the past 6 years. And I think I kind of always went into this direction because my mom was a retired OB-GYN. So I grew up seeing labor, being around labor, knowing about women's health and all that. So when I went to nursing school and wasn't sure what I wanted to do, I knew that labor and delivery would probably be at the top of my list. So I went through my clinicals and kind of narrowed it down. And then that was where I became a new grad nurse in labor and delivery. So it's kind of all that I've done. So there's pros and cons to that. Um, but it's been a really great job, especially going through COVID, getting to be obviously we had difficult COVID moms and that kind of thing, but for the most part, we got to be in a happier area than the rest of the hospital. So that was really helpful to make it through that period as a labor nurse.
Yeah.
Um, and that's kind of what led me there.
I love that. Yeah, that's so fun. And I'm sure you get to share a little bit with your mom too, just stories, and she can kind of help you through some tough times being on that floor because she's like, she lived it for so long. So that's probably nice too.
I call her every day after work on my way home from work, but
Yeah.
it's probably not a good idea some days. She's been out of practice for quite a while, so things have changed because it's always changing
Yeah,
uh,
that's true.
in medicine.
Yeah, that's very true. I love that. Okay, so what can you just explain a little bit about what a typical day looks like on the labor and delivery floor? I guess it's probably different at different hospitals, and I know your hospital's more you can talk a little bit about your hospital too. It's like high risk or something, right?
Yeah, so anything I say today is based off of me being a new grad nurse at the same hospital. So I've only worked at this hospital, which is very different. Every hospital is super different, and this is a teaching hospital, so we work with residents, whereas a lot of people work in private practice, which is a completely different story. And so I don't have any insight on that. So everything I speak to is our labor and delivery unit, which is high risk, but also sees anything from midwifery care and natural labor to the higher risk patients.
Yeah.
Um, and so basically, from a nursing standpoint, we show up to our shift and get our assignment, and it can be anything from a patient that is on bed rest, so our antepartum unit, which these
Mhm.
patients can stay with us for months or days while they're trying to figure out what's best for their labor course. And then also the delivery side. So all of us nurses do kind of both sides. So we get our assignment and jump in and see what the day holds, which we never know. So you could go to a C-section or have a vaginal delivery, have a natural vaginal delivery, um, or be with a bed rest patient. And when we do go to C-sections, we follow our patients, which I think is different for some hospitals too.
Yeah.
Some hospitals have like an operating OR nurse team.
Yeah.
We kind of follow through with our patients. So any given day is very different, and some days that's good, and some days that's not so reliable, but it
Yeah.
is what it is.
Yeah. And how many patients do you usually have at once on the floor?
When you have an antepartum assignment, you can have 4 patients, is kind of the classic assignment. And then with your laboring, if you're in early labor, you might have 2 ladies that are just working through early labor. And then as it progresses, you would go to one patient, and we're pretty good about that. So after active labor, 6 centimeters, you should pretty much be with one patient, or if there's something that makes that patient a little bit more high risk, you might just have one from the start.
Okay. This makes a lot more sense to me now, thinking back on my labor with Declan, because I went into the hospital already at 7 centimeters dilated. And I remember thinking like, oh my gosh, the nurse was so wonderful. She was in the room with me the whole time.
Yeah.
But that's that makes
Especially if it's your second baby and there's so a multip is what we would say, but if they're in active labor, you can't really trust them. So you don't know when they're going to spit that baby out. So you want to be there. I do know that some hospitals don't have this privilege, and there are some places that my friends have worked or travelers have told us about that do have two active women. And so I think that can come up where people might not feel that labor support
yeah.
because your nurse is spread thin. But we are lucky at my hospital that almost never that has happened to me.
Yeah, that's so nice. I remember that the nurse being in the room with me, and I was like throwing up, and she was holding the bucket for me like the whole time, and I was like talking to, like after the fact, like debriefing on the labor and being like, that nurse was just so amazing. I was not expecting that at all, but it makes way more sense. Um, but I feel like I did get lucky in that, because I'm sure that that does happen when there's not enough nurses on the floor to deal with that, or if there's like a ton of labors all at once or something.
Yes.
Um, so okay, so can you can you talk about like your role your role as a nurse versus what it looks like, I'm sure that you work with doulas on your floor. Sometimes I don't know, do you guys have doulas employed at your hospital, or do you just have like doulas that come in with their specific clients?
Yeah. So when we have doulas on our floor, it's because they're private with the client or the
Okay.
patient. And so they bring their own doula in. And so we can see a wide range of doulas, because
Yeah.
that could be somebody saying that's their doula and it's like their best friend, or it's a trained doula. So I think that that is the first factor that really determines our role with the doula. And there's two specific doulas that I can think of right now that I see often at our hospital. It's just because they must be popular with our
Yeah.
patient population, but they are incredible and helpful and understand the process and don't really get in the way. They'll
Mhm.
help their patient get, water and snacks and keep them hydrated. And some of them
Yeah.
are really excellent and will help them move. And because they know the patient so well, because they've probably already built this rapport and relationship with them before, they can reframe things that we say in a way that they know that their patient's going to listen. Um, and that is like a disadvantage sometimes when we do have a doula that will change our words. So it's helpful when we have somebody that is like, oh, you know what, she's saying this, and they explain it in a way that they know that that patient is going to accept a little bit better.
Yeah.
And then a non-helpful doula would be somebody that's like, that they're saying this, we don't really have to do that, or you don't have to do this. And it is important to know what you have to do and don't have to do, but
Yeah.
sometimes that can get in the way. So I think as a nurse, we try to feel out our doula. Well, we do feel out our doulas within the first like 10 seconds, and we know like, okay, today's going to be so helpful,
Yeah.
or we're going to really have to kind of work with this doula and tell them like, I'm sorry, but this is what we need to be doing, because
Yeah.
some things are medically indicated, and there's a reason that labor it needs to continue to progress, whereas others are a more natural course, and we do have time to wait.
Yeah.
So they can kind of do whatever they want with the patient, as long as they're not interfering with our monitoring if we need to, or anything
Mhm.
like that. And so there are these two that I'm thinking of that are very helpful with position changing, supporting, just like hydrating the patient, get like small things that sometimes as a nurse you don't when you're running around, or maybe you're having a harder day and you just can't get
Yeah.
that extra TLC. It is nice to have them there for that.
Yeah. No, that makes total sense. I remember being in nursing school, like seeing the different spectrum of doulas, like kind of what you're saying, and some of them being like, I was like, oh, I would never want to have a doula like that, if I was working as a nurse on the floor, just because, yeah, like you're saying, sometimes they can kind of get in the way if they're not, doing things in, I guess, not the right way, but just it, they need to, like, obviously understand their role versus your role in
And
labor.
anyone can say they're a doula because we don't ask to see the certification. So that is like a nice thing if they're trying to get like, their sister in and they don't think we're going to allow her, which we do allow
Yeah.
for visitors at my hospital. But so sometimes they'll just kind of put somebody in a doula role to get them in the hospital, which is fine if
Yes.
that's the way they want to do it. But then there are the doulas that are trained to be there.
Yeah. No, that's awesome. And then I guess for people that don't really understand, like, there's midwives in the hospital as well, and in your hospital you have midwives that are able to deliver, correct?
Mhm.
And then maybe you can just kind of talk about that care versus what the care from an OB looks like, and if there's any differences that you see in your hospital between the two.
Yeah, our unit has two, or well, our hospital has two midwifery groups. And then we also have our doctors and our residents because we are a teaching hospital. So there's differences in the two midwifery groups, but overall they're run by midwives. And so the midwives have delivery privilege. They're sole providers. They're not like a physician assistant or working under somebody. They are the sole provider, so they are the attending, they are the delivering clinician, that kind of thing. And I think that's kind of confusing for some people. So they can choose to get the midwifery care, which is a little bit more, I don't know what the proper term is, but they do focus more on the patient a little bit and helping that patient work through their labor progress. And sometimes it can be a little bit not slower, but on the slower end and a little bit more gentle and patient.
Mm-hmm.
Whereas the obstetrician is usually, they can take natural labor and all that kind of stuff too. But somebody
Yeah.
that wants to go natural will usually go with the, or I should say go not medicated, but
Yeah.
wants to go with the midwives. And so the doctors usually have a medical indication for that delivery. So if the midwife has a patient that has risked out and they're unable to follow their care, if the patient has preeclampsia and they're going to be on magnesium, then they'll just transfer the care to the obstetrician, which is really nice in our hospital because
Yeah.
your midwives are there. And then once you kind of get to the step where you're not able to be under their care anymore, you just transfer to the doc. And so it's a really smooth transition. And sometimes that's not even during the labor course, that might be after a long labor and now we have to head for a C-section. It's really nice because all we do is a quick phone call and then we're heading to the OR and that midwife can even be in the operating room with their patient just to like support them. Um, and so I think in general, I do really love working with the midwives. I feel like there's um, like I really can understand their approach, and
Yeah.
that's not to say that docs are bad or anything like that, but usually they are there to get the baby out. So it's a little
Mm-hmm.
bit more of a driven process um, because everyone's end goal is to get the baby out, but usually the doctors will push it to be a little bit of a quicker process than the midwife care.
Okay, that makes sense. And I'm sure you also probably have like a little bit more rapport with the midwives only because they're probably in the room more, I would
Yeah,
assume,
they
than
definitely are in
typically
the
male.
room more if they can be, and especially one of the clinics that we work with is very hands-on, and because they're a little bit of a smaller clinic, they don't have as many patients, so they can be in the room a lot, whereas the docs are running the entire board,
Yeah.
and they are there to do the cervical exam, and then they're out.
Yeah.
And so, yeah, the midwives, we also know them really well because they've been there for years or they're going to be there for years, whereas the docs are on a very rotating basis. So we get to know them for
Okay.
about 6 weeks and then they're on to the next rotation.
Yeah, that makes sense. Going from obviously your provider, you have the nurses in the room, you potentially have a doula with you, and then you have your midwife or OB, or maybe both, depending on the patient. And then you obviously most likely, hopefully, have a support person, a husband or partner, or maybe that's like another family member that's in the room with the patient. What, based on your experience, what does a supportive partner look like during labor? Like, what types of things have you seen that you're like, wow, this partner's being so supportive, they're offering this and this, what are the things that they can do to really be supportive during labor?
Yeah, right off the bat, I can tell you what a not supportive person does. So don't sleep through the entire thing. Don't play your video games, that kind of thing. There's a lot of partners that I think,
You've seen people that are playing video games during
oh my
labor.
God, yeah, like I really did have one dad ask me if we had a second monitor for my TV to play
No.
his, to set up his game, and he had all of his games pointed like opposite of the bed, like literally not even facing his wife, and was like, "Do you guys have another monitor?" And I was like, "Oh my gosh, this can't be happening." So there's partners that also just sleep through the whole thing, and I think sometimes they're tired, or they feel like, "Oh, I'm just going to stay completely out of the way," and that is just I. If they have that relationship with their partner and they've discussed that prior, maybe that is what she wants. But
Yeah.
I think that having it's important for the patient to have a conversation with their partner and be like, "Hey, this is kind of what I'm hoping with you." But also knowing that once the partner gets into that environment, some of them really don't do well, others really thrive. So maybe they're going to get nervous to be in a hospital environment or something like that. So it really depends on the relationship and the dynamics in the room and that kind of thing. But
Yeah.
a supportive partner can offer like counter pressure and things like that when the woman's in early labor. So different positions and kind of like we always like the slow dance, the like junior high slow dance, sometimes rocking the hips and that kind of thing can be good. I think one of the biggest things that I actually spoke with my coworker recently about that's important is knowing that the needs of the laboring mom can really change. So if
Yeah.
and to not take it personally. So if they're doing counter pressure and this mom is like, "Oh my God, you're the best. This is so helpful, blah, blah, blah." And then 10 minutes later, they're doing counter pressure and it's like, "Do not touch me." Don't get offended and think, "Oh my gosh, she's such a jerk. What am I doing wrong? She loved this 10 minutes ago." I think that as the labor progresses, things change so much, and she's not able to verbalize like what she's needing. So it might just be like a get off of me situation. And so get off of her and listen to her, and don't be like, "Oh my God, what you suck." Um, so I think it's just like the evolving needs of the laboring mom can be really difficult for a partner to navigate because it's confusing and it's
Yeah.
hectic and it's a little crazy sometimes. And so I think that's the best thing is just trying to try the counter pressure, try the different moves, offer water. If you offer water and she says no, don't offer water 5 more times. Like I think that they find a task that they want to do and they're like, "Oh, you should have water, you should have water." And it's like the mom is just like, "Stop, stop." And or, the whole breathing thing. Like there are times when as a nurse I do say, take a deep breath. And usually I'm saying that because the baby needs it for because I'm watching the fetal heart rate or something like that. And I think the partner's like, "Oh, I'm gonna keep telling her to breathe," and it's like that's not needed, and that is the last. I think that's from Hollywood, and sometimes we do need people to breathe, but a partner that is just sitting there and wanting to like give water constantly and whatever, and they're not receiving it well, that's not helpful. So just like being very aware of what it's being aware. So like just
Yeah.
take your feedback, work with it, try to be flexible, and if things get crazy, cling to the wall and kind of be out of the way. And
Yeah.
ask your nurse like if you what you're doing, get I think it's just getting feedback and just working with the room, which can be difficult, easier said than done.
Yeah, no, but that makes sense. And I think, like, I don't know, something that I always try to tell my clients, because I try to meet with the mom and their partner together, just because I think it's so important that they understand what's going on, and how they can be supportive. And kind of, I always say exactly what you're saying, which I think is something that's kind of understated because it seems simple, but yeah, like labor constantly is changing, and what you need is not going to be the same at 3 centimeters versus at 8 centimeters. Um, and so, yeah, I think even just based on my personal experience, like my body needed something at this time and something completely different later on. What do you see kind of going off of that, like, is the dynamic a little bit different when you have a doula in the room as well with the partner, husband, in the room? Like, do you see them being a little more hands off in those instances, or do they seem like, or does it really just depend on the doula and
It
how they're
really
working?
depends on the doula and the partner. So I've seen doulas that are like, get in here, do this, do this. And then I've also seen situations where the partner is just very good and is in there and doing it and that kind of thing. And
Hmm.
then I've seen situations where the doula is doing everything and the partner's sleeping on the couch, which is
Hmm.
fine if that's sometimes I do
Yeah,
think that the patient has set that up to be that way. And they're
yeah,
like, look,
yeah,
you get
yeah,
to go over there and you're going to be my person. And that's okay. So I don't really ever interfere with that situation. I take it as like, you guys have established this. I'm not going to interfere. I think once you go postpartum, those nurses are good at saying like, okay, dad, like time's up. You're not sitting on
yeah,
the couch. Like, let's learn how to do this diaper. Let's swaddle, that kind of
yeah,
thing. So up there, they're a little bit better at like interfering with the relationship and like making dad have or partner have responsibilities. But
yeah,
for me, I kind of think like, okay, you guys have figured this out and you brought this doula, so I'm
yeah,
gonna let you use him or her however you need.
yeah. No, that totally makes sense. And like, yeah, I think that's important too, because it is true. Like sometimes that's what they want, and that's why they're hiring a doula, because they know that for whatever reason their partner's not going to be the most supportive during labor. Maybe they're like just disgusted by everything that's going on. I don't know. Like some people have that relationship. So I do think that's important too. Um, okay. So I kind of want to just like take a little bit of a turn, but I think just talking to a lot of different women about labor and pregnancy and now on these podcasts, one thing that comes up a lot is that a lot of women going into labor have no idea what an induction is, and they don't know like what that looks like. They don't know anything about the different types of like the different methods of induction, because they don't even know what induction is. So can you just talk a little bit about that? And I guess I also know that it's a little bit different, I'm sure, to hospital. And I know in different countries they use different forms of induction too. Um, so can you just talk a little bit about what that looks like in your experience?
Yeah, so I think it is different hospital to hospital and just provider even can
Yeah.
decide different ways that they want to. So inductions can be for a bunch of different reasons. And so there are things called an elective induction as well. So it might be
Mhm.
a woman that as she's gotten post dates and she's
Yeah.
wanting to be induced. And that would be called an elective induction. But we do a lot of inductions at our hospital for gestational hypertension, diabetes, preeclampsia. So all the way from full term inductions to maybe a preterm induction for a medical reason. And so that also really guides things is if you're being induced electively, then we might have more time and we can do things slower. And we can take our time with all the methods we have. Whereas if you're preeclampsia and we're worried you're progressing to HELP and things are going downhill relatively quickly, then we're going to just kind of go for whatever we can the quickest, which if it would be needing to be the quickest, it would go to a C-section. But if we can
Yeah.
do an induction, um, there's a bunch of different ways. And at our hospital, we use a cervical ripening agent as kind of our first step. So people will hear the word Cytotec or misoprostol, same thing. And it's just a small pill that can be put vaginally or a lot. Majority of the time at our hospital, we do it in the cheeks. We just have it kind of melt into the mucous membranes. And it is a cervical ripening agent. So basically, you want to get the cervix ripened before dilation. So it's like the term ripen can really rub people raw. I
Yeah.
like do not like that. But it's a ripe cervix is a softened cervix and it has to be soft to dilate. So basically, this is the first step that we really like to use, and you can use it um, a few times. So the first time, or it's every 4 hours at our hospital. I think that at some
Okay.
hospitals it might be every three, but for us, we do every 4 hours. You can take it. The only problem is if you've had a prior C-section,
Hmm.
Cytotec or misoprostol is contraindicated. So some people will say, "Oh my gosh, I was never offered that," and it's probably because they were attempting a TOAC or a trial labor after C-section. And so they will not be offered that. And that's because it's a pill that melts in your mouth and then it's in your system. So it's systemic. We can't take it away once it's in your mouth.
Yeah.
Whereas the other agents, when we use something like oxytocin or the Pitocin that we're talking about
Mhm.
through the IV, if we have a distressing moment with the baby or something like that, we turn off the pump and it's off.
Yeah.
So it's much easier to control. So we don't want to risk a uterine rupture or anything like that with somebody who has had a prior C-section. So
Mhm.
someone with that situation won't get to see the side effect steps, and that's okay.
Okay.
But it is something that we do want to use if we can. So after the side attack, or maybe with the side attack, we can also do a cervical ripening balloon.
Okay.
And so that is the Foley balloon, some people call it. Some people call it different names. I don't
Mhm.
have children, but I've heard it can be the worst step of labor. So I do try to steer my patients away from it if we can.
Mhm.
But the doctors and midwives are going to offer it because it's a good mechanical dilator.
Okay.
So at our hospital, you insert the Foley, and this is done by the provider. So they put the Foley up through the cervix, which can be pretty uncomfortable, and then they blow up the balloon with water. So one of the balloons goes into the uterus, and then one sits down below in the vagina,
Okay.
and it's basically kind of compressing the cervix, so it is causing prostaglandin prostaglandin release, and mechanical pressure to open up the cervix. And then we're just trying to like pull. Some people put theirs to tension. I don't love to do that, but we'll pull it every hour or so. I tell my patients if you're in the bathroom and you get adventurous, you can give it a tug and just throw it away when it comes out. I don't need to see it. It can be pretty bloody and mucousy, but when it comes out, we say you're 3 to 4 centimeters.
Okay.
And so it's something that also helps. You can do that with the side attack. We do not place balloons at our hospital if your water is broken or if you're ruptured, but some hospitals I've heard do.
Okay.
Just as an infection risk, we don't. So that's another step that I'll advocate for my patients. If I feel like they're 2 centimeters and they're doing so well, they're contracting, I'll be like, you don't have to have the balloon. This is your right. Um, because it is something that you can say, I'd like to wait. If
Yeah.
you're medically indicated to be induced, sometimes we're going to say, like, look, we got to get this going. Let's do the
Yeah.
balloon. But if we have time, I don't think it's a bad idea to wait the next 4 hours, be like, okay, can I see if I make change? And then if I haven't, then we can try the balloon. Just because the balloon can be a really uncomfortable process.
Okay.
However, I have had patients that get the balloon and they're crawling off the bed, they're screaming, they're crying, they're like, "Get the balloon out." And then other patients get the balloon and are sitting there and they're like, "Oh, it kinda hurts."
Oh.
So, I have no idea. I've never had a balloon, um, but I think it's kind of a range of pain. And then
Yeah.
basically after you've done those steps and you've ripened the cervix and you're going forward, the next step would be the Pitocin or the oxytocin, IV drip. And that is something that we just titrate to try to get the contractions to be every 2 to 3 minutes. We want a
Mhm.
consistent and painful contraction pattern to make cervical change. And so we'll use the Pitocin to do that. And so it's
Yeah.
really something that we can really closely titrate to get exactly how we want. We titrate it based off the contractions and off of baby's tolerance to labor.
Okay. I kind of want to just go back to talk about the balloon a little bit. And basically only because I'm saying I've had a client who had the Cytotec and the balloon at the same time. How do you like you're saying you're kind of talking to your patient and saying maybe wait and see? Like how do you get that across to people? Because I think that so many times like people are going into the hospital and they just have no idea what these things are. So their provider comes in and says, "Hey, we want to do this and this," and they're just like, "Okay, great," like they
Yeah.
have no idea. How do you get that across to people?
This is kind of hard because I think it depends on your nurse and how much they're going to educate you from the start. And again, that can be based off of not if you have a bad or good nurse, maybe they're busy that day or something.
Yeah.
But I'll
Yeah.
try to go into my inductions and just be very honest. I do have some nurse friends that are like, I can't believe you told them that, because I'll run from like, we're here and then we might go to C-section later. And everyone's like, oh my God, why would you do that? And I want my patients to know every step the scary, the bad, the good. That way, when we go to that step, I can say, remember, I said this might happen. And this is, so there's a little bit of not complete shock because there's already so much shock when things change.
Yeah.
And so I go into my inductions and I tell my patient right off the bat, I'm like, okay, this is a very step by step process. We do these inductions so often that if
Mhm.
you feel lost in this process, please raise your hand and be like, wait, can we stop? Can we talk about things? And I'll
Yeah.
warn them that, the doctors comes in and says, oh, we're going to do this next. We're going to do this next because we are just going to the next step. We're going to the next step. And you can say, oh, can we wait on this one? And I tell them as their nurse that I might step in and say, oh, you know what, right now I do think we need to go to this next step because your baby's not tolerating it, or your blood pressure is getting really high. This is getting dangerous. I think that we need to continue. We should do the balloon. So sometimes I've told them, like, you should say no. And then they say no. And I'm like, well, we should
We have
actually
to.
do it. So I do warn them, but I tell everybody, and this is a process that we're going to do, but it's your body. And if you're
Mhm.
confused or if you need clarification or if it doesn't sound like something you want to do, you can say no. We are going to
Yeah.
tell you what is recommended and what's medically indicated for this baby.
Mhm.
And ultimately, you are the boss, which never feels that way because, like you said, your
Yeah.
provider comes in and says, hi, okay, we're going to start with Pitocin this morning. And you can say, wait, was there, the riping? And then maybe they might educate and say, oh, no, your cervix is already so soft. We're good to go to
Yeah.
the next step and whatever. But at least, but it is so hard for a patient to advocate because they don't even, one, know what to advocate for. And two, if their
Yes.
nurse is not saying anything and just saying, okay, let's go. Because a lot of nurses will just kind of be like, you know what, I'm busy, I'm tired today, whatever, we'll just do that.
Yeah. Yeah. No, that makes
So I
sense.
think it's important to stand up for yourself and advocate for yourself, but also do that while listening to the advice and
Yeah.
getting educated. So if they say, this is the reasoning, then say, okay, I understand that or whatever.
Yeah.
And just have a little bit of trust in the healthcare team that they are trying to do what's best for you and baby. And maybe that, once you stand up for yourself, then you can kind of say, like, okay, I trust whatever step is next. But you can advocate to pass on that balloon because not everybody needs a balloon to have a baby.
Yeah.
However, if you get a balloon, you might progress a little bit quicker. So some people do really like the balloon because it moves things
Yeah.
along.
What is there a difference between like if you go into the hospital already dilated or whatever with which step you start with,
Mhm.
or do you always try to start with the side attack normally?
No, so that's a really good question. So side attack is best in early labor. I mean, we would never give a patient that shows up at 6 centimeters. We're not gonna be like, oh, let's augment you with some side attack. That would just
Yeah.
literally never happen.
Yeah.
So it is for early labor. It's that cervical ripening stage. So when you get your exam, they're gonna tell
Mhm.
you your dilation, your effacement, which is the cervical ripening for
Yeah.
a better word of what I'm saying, and then the station, which is just how high or low the baby is in your pelvis.
Mhm.
So that middle number is from 0 to 100%. And you want it to be 100%. That means 100% effaced is completely ripened or softened to be able to dilate.
Mhm.
So if somebody's cervix, they come in and let's say they're like 380 and -1, they're already pretty ripened and it just doesn't it's normally not going to be the next step to do a side attack. They're probably going to move to Pitocin, or they could offer, if the baby's low enough, they could offer an AROM, which stands for artificial rupture of membranes, which would be breaking the water. And that would be a good next step if it's safe because it's releasing oxytocin itself. So when you break your water, it does release oxytocin and progresses the
Mhm.
labor as well. So that can be a little bit more of a natural way to progress the labor.
Mhm.
If somebody comes in and they're 150 and high, that would probably be somebody that could get the side attack. Um, or sometimes you'll hear somebody say their fingertip thick and high. And if it's thick,
Mhm.
that's saying, we still have a lot of ripening to do with the cervix. And that would
Right.
be a good
Okay.
side attack.
And talking about breaking the waters, what can you just talk a little bit about what that looks like? Because I know a lot of ladies that have no idea, that they come with the little instrument to break your water and they're like, what the
Yeah.
heck is this? And then also just when that's kind of indicated, I guess, like at what point during labor would you as a nurse be like, yeah, I think this would be a good idea for them to come and like break your waters now? Because I know there's times where the waters get broken maybe a little bit too prematurely, and then that might cause some issues.
Yeah, and there's a study that's being done right now about breaking the water early and like all through all the stages of labor, because right now
Mhm.
it is thought to be that if we break the water too early, once your water's broken, it is an infection risk. So it does put us on a time clock. So we want to get the baby out. It depends on the provider. So I won't give a time
Yeah.
frame because that can be confusing, but it kind
Mhm.
of starts a time clock, whatever that your provider's clock is. And so breaking it at 2 centimeters is kind of like, oh shoot, well now we're not even into active labor and our water's broken. So there's
Yeah.
actually so many scenarios. I think my least favorite part of this job is that there's not black and white answers to anything. And so
Yeah.
it's really hard because I could say something and then someone could be in this exact situation and do it and it might not work for them.
100%.
But if the baby is low enough, so you have to have the baby to be low, because if the provider is not um, confident in the rupture, it could be really dangerous. So when the baby's head is very high and they break the water, the cord could come underneath the baby's head, and that would be a cord prolapse, and that's an emergency C-section immediately. And so if that were to happen, the provider will stay on the bed with you, and their hand is up trying to elevate the head from the cord, and they basically ride the bed to the OR, and that is a
Yeah.
very quick transition. If the doctor thinks that they have had a cord prolapse, they will say, "We have a cord. We will unplug everything, and we're in the OR in less than a minute." So that's a unique situation, and I'm so sorry for people that have gone through that. It is very scary, and that is why they don't do the rupture on everybody. But it can happen, and it's a risk, and that's just something to be known. And we do tell our patients that when we're going to go break their water, we just say, the risk is cord prolapse. I don't feel like this is something that is going to happen to us, but we do have to state the risk. The
Yeah.
best patient that this is for is, again, that could be a million different things, but in my
Mhm.
opinion, if I were trying to go natural, which I don't think I'll do one day, but if I was going without medication and I wanted to progress my labor and I was, at 7 centimeters and I'm like, I do not want Pitocin. I do
Mhm.
not want any augmentation. I don't want anything. I want to do this by myself. And if I'm just still at 7 and I'm not making any progress, I really encourage these patients to, if the baby's low enough, to do AROM, because it will release the oxytocin in your body, and so it's
Yeah.
like getting a little bit of pitocin from us. If
Yeah.
you are stalling
Better
yourself,
because it's your own body and not like artificial, right?
yes, yes, but the artificial is like the same ish thing, so it's not like the worst thing. And some
Yeah.
people hate pitocin and are so afraid of it and are anti it. But what I do tell people is we can titrate it and we start it at 2 or 4, depending on the provider. Some people get it started at 2 and they deliver at 2. Other people
Mhm.
get it at 2 and then they get all the way up to 20 or 40 in some extreme cases. But
Yeah.
so it really kind of depends on your body. It depends on the receptors, all that kind of thing. But the AROM will provide the patient with a little bit of a boost, and it's going to progress the labor, or we're going to get to a point where we're like, okay, we're still stalled out at 7. Maybe this baby's malpositioned. Hopefully, we're already trying all the positions. If she is going unmedicated, then she's probably trying most of the positions.
Yeah.
And so then it's time to think about, what's the risk and benefit of a vaginal birth at that point. But there's a lot of times that an AROM, it could be very helpful to progress the labor, but there are times when it could be too dangerous. So patients will say, "Can't you just break my water?" And
Yeah.
you should not push for that. If the doctor ever does not want to do it, do not let them do it, because there's a reason
Yeah.
that they're hesitating.
Okay. That's really great. That's really great to know. So, and then you kind of hit on this, but I think that's another thing is so many people talk about like, I don't want to get the pitocin because like, I hear the pitocin contractions are so different than normal contractions without pitocin. And can you talk a little bit about that maybe, and just like what you've seen in your personal experience, like labors with moms that have pitocin and that don't? Is there a difference in how they're reacting to the pain from those contractions?
Yeah, so I am transparent with everyone, and I do tell my patients, I'm like, look, PIT can take you from 0 to 100. And
Hmm.
the end goal is that we want to get this baby out, especially with a indicated induction. So
Yeah.
sometimes they're so afraid of it. And I try to remind them that this is not going to be a pain-free process. And we want to get this baby out, especially if the baby is stressed. Then I'm like,
Hmm.
we have to move towards something. And it at this point, if we're either going to turn on the pit or go to a C-section, let's turn on the pit and see if we can
Yeah.
progress this. But I do warn people that, these contractions are much stronger. They're going to release what we need to make a muscle contract. Your uterus is a muscle. And I think that's also something, I don't want to say it's funny, but a lot of women don't realize that their uterus is a muscle and it's contracting. So when you have a really bad calf cramp or something like that, that's your calf entirely contracting. Your uterus needs to do that every 2 to 3 minutes to get this baby out. So it is going to be really intense and strong. Um,
Hmm.
but it's kind of what we have to do. So if there's a patient that wants to have an epidural and they're 4 centimeters and they were like, I really wanted to wait to get to 6, I will say, okay, well, we're going to start the pit now. Do you want your epidural before? Or I'll just have it, I'll be like very prepared to get them an epidural. So I'll have them already sign their or not C-section consent, but when anesthesia comes in, they actually do the consent for the entire thing. So that's not something
Okay.
to be afraid of or feel like you got judged when some patients say, oh, he came in and he went through the C-section consent. They do that all at once. That way, they just cover their bases for everything.
Yeah.
And so I'll have them get consented before I start the pit. That way, when they're in so much pain, then I just call and I'm like, okay, we need that epidural. It's a little bit of a smoother process than trying to go through a consent during those Pitocin contractions.
Hmm.
But yes, I do think they're stronger. Like I said, don't have kids, so
Yeah.
I don't know. But there are some women that get put on Pitocin and then they're like still working through it and still doing their thing. And then I think just the other day I had a patient deliver unmedicated on PIT and
Yeah.
she didn't know the difference. So
Yeah.
I think it really depends on the person, their
Mhm.
oxytocin receptors, and just like their pain tolerance and the way
Yeah.
that people
No,
work through labor.
I think that makes sense. And I love what you said too. Like, I think it's important to remember, like, you don't, obviously you don't have to get these things, but like you said, okay, if we have the choice between going right to a C-section and trying something before that, like, let's try this first. And then, that's the next step. So, I try to like tell my clients that always, like, try to start with the lowest thing that you can possibly do first on the totem pole, and then let's work our way up, as long as everything's fine and like there's no, baby's not stressed and you're doing okay. Um,
Yeah, and some hospitals don't have in-house anesthesia, and maybe their docs aren't in-house. So I'm again speaking from a
yeah,
teaching hospital where I have all the resources there. So I think some people might hear that and say like, "Oh my gosh, like no, by the time the baby got stressed or whatever, we'd have to wait for anesthesia to come and all that." I work at a hospital where I can call anesthesia and they're going to most likely be to my bedside within 20 minutes at
yeah,
most. And if it's an emergency, they're there.
yeah,
And so that's kind of a fortunate situation for me.
yeah. I do think that's kind of is interesting to hear too, because I've been talking to people, and some women have been like, yeah, I asked for an epidural and the anesthesiologist wasn't there, so it took like an hour and a half or 2 hours, and by the time they got there I was like already complete and didn't even get the epidural.
Yeah.
um, so it is obviously dependent on the hospital and where you're at and where you're laboring at.
And you can
um,
ask a hospital, do you guys have in-house anesthesia? So is your anesthesia on your floor or even in your hospital?
yeah,
Because that will kind of tell you how
yeah,
available they might be.
yeah, that's a good point. So now that we're kind of talking about epidurals, let's just kind of jump into that. So what can you just explain a little bit about what an epidural looks like at your hospital? I've talked to some girls overseas actually that have gotten epidurals, and they have to go to like a different room that's basically looks like an OR. Everything's sterile, everyone's like gowned and gloved, blah blah blah. But do you just do the epidurals in the room? Because that's the experience that I've had.
Yeah, so we do them in our room. We do only allow one person to be in the room with you. So usually
Okay.
that's the partner, but sometimes they'll choose like their mom and send the partner out. And so it is a sterile process. So that's why we only allow one person. So it'll be
Mhm.
your nurse, your partner, or whoever you choose to be in there, and we will have masks and hat on. And then the patient will have a hat on, but they don't have to have a mask at my hospital because they're facing the other direction. So then behind
Yeah.
you, you have your anesthesiologist, maybe the resident, maybe the attending will come in, or we have CRNAs at our hospital, which are nurse anesthetists. And so those are all the people that would be able to place your epidural. And then you basically sit on the edge of the bed. I'll try to continue to monitor the baby throughout the process.
Mhm.
And we just say like chin to chest and kind of curl over your baby, which is a difficult position to do when you have a pregnant belly. But I think if your nurse can help you with the positioning and really like make sure the shoulders are straight and that kind of thing, positioning is the number one thing that will help the epidural get placed quicker. So if you are in the correct position, they can find the spot easier. It is a difficult thing. That is why they're skilled physicians to do this.
Yeah.
But so it might take a moment. And so I think patients sometimes are like, what is taking so long? What is taking so long? An epidural placement could take anywhere from 10 minutes to I've been in upwards of an hour. That is a
Wow.
very stressful placement and it's not ideal at all, but it's a process and it takes time. So I tell my patients, we're gonna, be in this position, we're gonna work through your contractions, and they say, oh, I can't do it, I can't do it. I think that you can sit still for this if you want this epidural, which is going to take away the pain, but it is going to be a hard 20 minutes. We're going to focus through this and get through it. If you cannot stay in this position, you need to tell us, and then we'll make sure that it's safe for you to sit up. So I also tell people the best thing you can do in this process is talk. And I'm like, the worst patient for this process is the one that gets scared and doesn't say anything because you're the
Mhm.
only one that can feel what's happening on your back. And so if the doctor asks you where'd you feel that and you're just like, no, I don't want to say anything, that's
Yeah.
0% helpful and we're going nowhere. So saying oh, my left, my right, or saying I don't know, I always say I don't know is a better answer than no answer because usually I don't know means that they are in the center because they can't really feel it. And so um, being able to talk and be present with that procedure is really helpful. And then just working on that difficult positioning and having your nurse kind of like all hold their shoulders and kind of roll forward, um, and just kind of explaining that. I don't think that that's something that people need to panic and be like, oh, I need to go practice my position for my epidural because you have no idea how you're going to be doing in that moment. You
Yeah.
might get an epidural when you're actually not in a ton of pain because you're just
Yeah.
needing it at that time. And so it might be a little bit more of an uncomfortable process for you, or you're getting that epidural when you're complete. We've given people epidurals when they're complete. And so, yeah, they're going through so much pain. So they're like not even remembering what's going on their back.
Yeah. Yeah.
So you can prepare, but I don't think there's too much that you really can be prepared for.
Yeah, that makes sense. And so I guess with that, do you feel like just based on your experience, the labors that you've seen, is there, because I know people will say, like you kind of mentioned, people want to wait until a specific, they're dilated to a specific number to get an epidural. Maybe they're saying like, oh, I want to wait till I'm in active labor, like 6 centimeters, and then I'll get the epidural. Is there an ideal time from what you've seen, or does it really just depend on the labor and how everything's progressing?
Yeah, I'd say it entirely depends because somebody might have a number and that's great, and I'm all for that. Especially if it's to active labor, I think that's a great goal to have because
Yeah.
then you're so moving around, you're able to eat because you're on clears once you get an epidural. So you're eating, you're moving, you're doing all the things until that process. If you're wanting to get to 6 and you're 4 and your baby's looking very stressed and it's not looking good and I'm concerned that we might go to a C-section,
Hmm.
those are the patients that I'm like, you know what? You were going to get an epidural anyway. And yes, you're not at 6, but this baby's really looking like things are just stressful. And I'd like to get you an epidural, get you more comfortable. Sometimes
Hmm.
getting the patient more comfortable is key too. So um, I'll have that conversation with them if I'm trying to prepare for maybe, you know, an OR situation. And then sometimes we don't go. So
Yeah.
other times the patient might get to, let's say they didn't have a number and they're 7 centimeters and they're like, oh my gosh, I'm so close, I'm so close. And they just do not want this epidural. I will talk to them and say, you're exhausted. It's been 3 days of this, and
Yeah.
your body is just like tapped out. And I tell people this all the time, but I've seen it countless, countless times where they're anti-epidural, anti-epidural. We finally convince them. They get the epidural and they're sitting for the epidural in that position for, let's say, 20 minutes. We lay them back down and they're complete and they have their baby. I think the when your body is under so much stress, you have the adrenaline, you have everything, but a lot of people are holding themselves so tightly that they can't relax. And it's not like you can't just tell them to relax and they can relax. They literally can't relax their mind, their body, anything. And the second they get their epidural and they just kind of like relax into it, their body dilates and they're complete. That has happened so many times. So if I have somebody that's kind of stalled out and they're going unmedicated, I'm always like, oh, maybe we can get an epidural and this is going to work. The biggest thing is just about moving. So if you are 4 and you're dying and you're like, oh my God, I'm only 4 centimeters. I cannot get this epidural yet. You
Mhm.
can get an epidural and just tell your patient or your nurse, which they should already know, but
Yeah.
they might not. It is really important to me that I'm moving a lot. If you have a doula, then perfect. They're going to be moving
Yeah.
you. It's fine. But
Mhm.
if you get the epidural and you're 3 centimeters, you're not a failure and it's okay. But what you do need to do is change your position. You cannot get in the bed and go to sleep for 8 hours and wake up and have a baby. It's not going to
Yeah.
happen. And so some people get the epidural and they're like, well, I thought I could, sleep through the night now. My nurse keeps coming in every 45 minutes and moving me. And we do have patients that are like, can you please stop coming in? It's like, we are still trying to mimic natural movements and labor and all that. And
Mhm.
no woman has ever just laid on their side for 8 hours and had a baby. So,
Yeah.
um, using different positions and having your nurse come in. There are nurses that do every 30 minutes.
Mhm.
I will do like 30 minutes, depending on like if the baby's tolerating. I do it like 30 minutes, but an hour is okay, in my opinion. But really moving that patient every half
Mhm.
hour to an hour is so important. And there are some babies that don't tolerate like a left side. So this is why, again, nothing is black and white because I could
Yeah.
say, oh, move every 30 minutes. And then you're in this situation and you say, oh, my nurse never moved me on my right side. There's
Mhm.
probably a reason. Like sometimes there are positions where the baby does not tolerate it. And I'll tell my patient, like, shoot, now we can't ever go back that way because the baby's not doing well that way.
Mhm.
And so ideally, we would be moving in all sorts of positions as long as the baby tolerates it.
And what does that look like? Can you explain a little bit about the peanut ball? Because I know a lot of people don't know what that is and don't know what that looks like. Are you using that a lot in your hospital?
Yeah, I'd say I use the peanut ball on every single patient.
Okay.
I would say every single patient that's epiduralized. I would
Yeah.
not make somebody do it when they're going natural. But we actually have a gal on our unit right now that her project is all about the different types of balls. So whether that's
I
just
love
a
that.
ball that you're bouncing on for labor or peanut balls, we're actually researching like the different sizes and when it's helpful and whatever. There's a ton of different movements you can do with a peanut ball, so you could always look that up and see different ways. But the
Mhm.
classic between the legs is works. It's just that the setup is really important. So making sure that your nurse knows how to help you get in that position is important, and it's not really just putting it between your legs. It's actually that the
Yeah.
leg on the like your bottom leg, the one that's on the bed, is
Mhm.
straight. And then you do want to turn over so that you're almost laying on your stomach. So you put your
Yeah.
leg up over the ball. And I always tell my patients, I'm like, you want to feel like you're actually laying on your stomach. So
Mhm.
completely turning them and then doing that for about half an hour and then switching and doing the other side. There's also like my favorite position right now is because my one of my best friends at work told me to do this, and we always laugh because now since we've had like 4 different patients that have been stalled out or not progressing, and then we do this move and it works. So it's like our favorite thing right now. But
Nice.
I don't know what it would actually be called. I call it extreme sidelining, but there's
Okay.
probably definitely a term for it. But we grab out the stirrup from our labor beds and pull that up, and we instead of the peanut ball, we'll put that top leg up on the stirrup. It's a really
Oh.
extreme position, but it really opens the hips. And so
Mhm.
I'd say as a patient, it's just important to try to tolerate the position if you can. A lot of labor positions that we will do, there's one called like welchers that I think it's Welch's where you're like hanging off the bed. I've tried it a few times, but some of these things are really uncomfortable, but there's a
Yeah.
reason for them. And so we're trying to move that baby or turn that baby. And there's times when, like I said, with these patients that this position has been working, where we open those hips, that baby spins, and then you're complete and +2, and you have your baby. So
Yeah.
it just needs to knock the baby into the right position.
Mhm.
And so I would say try to tolerate it. I think a misconception is, oh, once I get the epidural, I should feel nothing. And you are going to feel pressure because we
Yeah.
cannot take away the pressure of a human coming out of your body. It just
Yeah.
cannot happen. And so you will feel something. And so try to like just still work with that a little bit and work with the discomfort because it will be worth it and it will lower your pushing time and all that. So
Yeah.
hopefully those positions work. And if not, like a baby might be asynclitic and might lead to a C-section.
Yes.
And that is indicated because the baby's just unable to turn.
Yeah. But that, I mean, I think that, I mean, everything you're saying makes complete sense. One, but also like just from my personal experience, like I, exactly what you're saying. Like I was 9.5 for what? Like, I mean, hours and hours and hours. And I just was not progressing. And that then just would not come down. And I got an epidural and I was on the peanut ball and I was complete. And it was just like I just needed that relief and I had been in labor for 3 days. So I listened to my body and what my body needed at the time. And um so I think that I feel like that's just so important too. Like knowing, okay, I'm stalled and I didn't want the epidural. Like I went in thinking like I really want to go unmedicated. I'd had a C-section before. I really didn't want intervention. But at that moment, I was like, okay, I need to do something because this is not working. So I just tried to listen to like what my body was telling me. And, but again, like I knew, okay, if I'm going to get the epidural, I'm going to say to my nurse, like, get me on the peanut ball, get me moving. I don't want to be just laying. Like I need to get complete, and I didn't want to just be like sleeping for hours. But I
And
did
it's
need to
okay to like take that quick. I'll tell people like, okay, you can have your quick epidural
yes.
now. I'm going to give you an
Yep. That's
hour to
exactly.
sleep, and then we're moving.
So that's exactly what I did. And it was just so nice because I hadn't slept in 3 days. I'd been in labor for so long. So I do think there's moments where, even though like you're not a failure, obviously, for having an epidural in that situation, it was what I needed and it worked and it was great. Um, but yeah, so I think that's super important. And then kind of going off of that, we're talking about positioning without the epidural or even with it. Like, what are the different types of positions that you use with your patients? What do you think works the best? Are there different positions that you think work well during different stages of labor? Or is it kind of what the patient is tolerating at the time and what they do? You try to like kind of lean into what they are like liking, I guess. Like I always try to tell my clients too, again, kind of what I was saying. You have to listen to what your body's telling you. Like it sounds weird, but in labor you kind of can like feel things. And I think, like you get into certain positions and you're just like, this is so uncomfortable. I can't labor in this position. And so try different things. Are there different positions that but I guess what I'm trying to ask you is just like in your experience, are there different positions that you feel like are really helpful with helping the baby progress? Or is it kind of just dependent on the labor?
Yeah, I'd say for somebody that's going unmedicated, I let them like do whatever they need because
Yeah.
I just feel like their body's kind of taking over and they're gonna do it. The
Yeah.
Sometimes I will tell them to go sit on the toilet. A lot of them love sitting on the toilet and find that like super comfortable. Once you
Mhm.
get pushy, I do not let you stay on the toilet.
Yeah.
Like, not on the toilet, baby. So there are a lot of moms that are like, I'm not getting off this toilet, and they do not want to get
Yeah.
off the toilet. Once you start pushing, we should just get
And
off the
sitting
toilet.
backwards on the toilet, right?
Yeah, both ways. Both
Both
ways
ways.
are
Okay.
comfortable. Yeah, some people the way I like sometimes it's like hard to go backwards, and so um, I just yeah, people will just like go to go pee, and then they're like, oh my god, I can't get up. This is like the most comfortable I've been.
Yeah.
And so that's that. Obviously, if you have an epidural and you're in the bed, we try to do hands and knees. Sometimes can be really helpful. If your
Mhm.
legs are too dead from that epidural, obviously we can't get you into that position.
Yeah.
But you can try to have your nurse help you and get into hands and knees and kind of be hanging over the top of the bed. You bring the bed up so that you're like sitting straight up in it and then you kind of hang
Mhm.
over. That's a really good position for baby's placement, all that. If you want to get crazy, you could lower the foot of the bed and kind of do like a lunge and put your one knee up on it and then switch. Those are difficult movements with an epidural because your legs are heavy, but some people get fantastic epidurals that they can move really well with, and
Yeah.
those are good hip openers. And I do encourage people to do it, but if you're like so tapped out and so exhausted, I want you to do those a little bit, but I don't want to get to pushing and you be like, I'm exhausted because we just did so much and now I can't put my energy into pushing. So
Yeah.
you do always have to remember that you do have your next step, which is
Yeah.
pushing, and that could take anywhere from 20 minutes to we allow our patients to go up to 4 hours.
Mhm.
And so you do have to have a little bit of reserve for that. But so I kind of, I guess to answer that question, if they're in the epidural, we do the peanut ball, we do all sorts of moving that way. But the hands and
Mhm.
knees can be helpful. Or if you're unmedicated, it's kind of like I just watch. Some people are, crawling on the ground and that's their thing.
Yeah.
I just let them do whatever they want.
Okay. I love that. Okay. So then moving on to that pushing stage, what types of positions do you guys allow people to push in different positions? Are you only like really on the back? One, but two, like if they are able to push in different positions, do you find certain positions are more helpful? Do you see less tearing with certain positions? How do you kind of coach your patients through the pushing stage? Because, well, I guess also, okay, we can talk about this after the fact, but maybe you can also talk a little bit about like pushing with an epidural versus not, because I feel like that's also probably a little bit different.
Yeah. So basically, when it's time to push, we always say, "Okay, it's time to push," and sometimes that can create like extreme panic in patients, and other times they're like, "Oh my gosh, yay!" So if that's like a moment that is way too overwhelming for the patient, we'll say, "You know what? Looks like you need a moment. I'm going to explain this a little bit. We're going to leave for 5 minutes. You're going to regroup, and then we're going to come in and do that." You do need to be in a good headspace to be able to do that. So if it's like so panicking to you as a patient, I always say like if the baby's doing okay, you can say, "Okay, can I have a minute to wrap my head around this? Because maybe it happened so fast or whatever."
Yeah.
But sometimes we might say, "The baby's really not looking good. We got to push." And sorry, this is just what you have to do. And then
Yeah.
we do get a little aggressive. And I think um, no patient has ever said, "Oh, you were so mean to me." If I'm like yelling at them, it's always like warranted if we're like really just going after it. So sometimes we'll have a huge decel. We run in, we check them, they're complete. The baby's still down, and we're thinking, "Oh, we might need to go to a C-section." Then we
Hmm.
check her and say, "Oh, she's complete," and we'll just go right at it and don't care what position you're in, or anything. Everyone's just like push, push, push. We're trying to get the baby out.
Yeah.
Um, Otherwise, if it's a controlled environment, you're complete.
Hmm.
I tell every patient, okay, I'm going to tell you how we push, how I've seen pushing work. If you don't want to do it this way, that's great. If you have another idea, that's great. And then you can do your own thing. If they do their own thing and it's 30 minutes in and I'm like, this was the worst way to push, I'll give that advice then. But I don't want to shut them down from what they're feeling like their body is telling them to do right off the bat.
Hmm.
I tell them, okay, standardly, we're going to push on your back. This is for like an epiduralized patient. We're going to pull both your legs up. I always say knee to ears, which is very aggressive, but just to kind of get the idea that we're really opening up your legs and pulling them back. I like my patients to reach their hands, both hands kind of underneath their legs and kind of pull up. And then I have the partner, if they want to stay up at the head, that's totally fine.
Hmm.
But I have them kind of support the foot. And it's really important to know that they're not leaning in and like pushing because we get so excited that we kind of push with the patient. And you don't want to pull the patient's hip back because you could hurt their hip. So it's
Okay.
really them doing the pulling. And then I say, we're going to do 3 pushes per contraction. So we do about 10 seconds push and then let your breath out. Take a big breath in, go right back at it. We're going to do that 3 times. Um, this is how, it's a very standard way. If this doesn't work for you, that's great. We'll try other things. We can try being on one side and with a leg up. We can also, with an epidural, we can do hands and knees pushing. So having them up and kind of sitting into it. We have squat bars we can try to put the legs up on. People do tug of war. I'm the worst tug of war nurse in the world. I do not do it that often. But if that's something you want to do, you can ask your nurse to see if they have a bar. They should. And then they just kind of pull. It's hard, but it's hard to get. For me, I don't like it because my patients are always putting it in their upper body. And so they're working so hard with their upper body. But there are countless times it has helped the patient. But we just kind of do that. And a lot of times pushing can depend on the baby. So some
Yeah.
babies are doing really well with pushing. Other babies, we have to have them tilted all the way on the side for the pushing, or maybe they are just tolerating flat on their back. Sometimes that is a really good position for the baby. Um, so it's hard because there's so many variables. If you're going unmedicated, you could be standing, you can be squatting, over the bed. You can really push however you want. I don't think there's a bad way to push except for like having your legs shut. And there are different variations of pushing that we'll try, especially with the epiduralized patient. There is one where you do knock kneed for a little bit.
Yeah.
And when I was taught that one, that was like really interesting because they had us kind of hold the back of our hips and see when you move your legs from knock knee to not, you can really feel like the back of your hips and your pelvis open. That one can be really confusing for the patient, but I'll do
Yeah.
like 2 contractions and I push their knees together so that and that one's really, they're like, what are you doing? Why are my legs closed? But that one's not to be done long term. There's different stations and different times to do pushing, but otherwise it's just give it your all. I coach closed glottis is I think what they call it. So like bearing down and holding your breath with those contractions. I do think there's so much more power in that. When the mom is letting their breath out, you're just losing so much strength that you have. So if the patient really wants to do open glottis pushing, I will allow it. But if it's not making progress, then I'll say, you know what, why don't we try to hold your breath and really just bear down like you're constipated, like you're trying to poop, all that kind of stuff, because that's the way to get the baby out.
Yeah. I love that. Is there like a position that you see where you're like, wow, I've seen so many women do this position pushing and like they're not tearing a lot? Because
Oh
some
yeah, I
people
forgot that
say,
question.
yeah, like some
Well,
people will say, oh, side lying, like there's
I was
some
gonna
research
say,
now
I
that side
had
lying is beneficial, but
yeah, I had this nun midwife once, and we were pushing, and she kept being like, "You have to go on their left side. They have to be on their left side." And I was like, "What is she talking about?" And then she was like, "That's the only way they don't tear." I guess that must be somewhere that sideline reduces tearing. I haven't done a lot of research myself on that. So I don't know, but I have been told that. So I do keep that in mind. For me, when I'm thinking about tearing, it's that final stage. So when, whether we're on your back or side or whatever, I have had people push on their back and not tear. Um, it is so much easier to not tear when it's your second, third, fourth baby. So when primates are like, oh my God, I tore. Sometimes they only have a very small tear. And I'm like, that's really, really good. And so when you're crowning, the pressure is so intense that some women just freak out and push through and get the baby out. And that is what causes a big tear is the final push where you just kind of lose control and push just to get it done. So I will warn my patients before and say, okay, we're getting close. So when this pressure is so intense, I'm going to lean down and say, small pushes, and please try to do that because what we're doing is allowing the baby time to stretch. Hopefully, the baby tolerates it. Some babies, their tones are down and their heart tones are down, and so then we just say, "Oh, sorry, you're gonna tear, and we got to get the baby out," and that will just happen. But if we can allow it, then we will let the baby crown slowly, and then it's a lot of some people even do feel the burn with the epidural. So burning, pressure, all that. But I say, take a little breath, take a breath, and then just have them kind of like very slowly breathe out and just a slow ease. And that allows all that tissue to tear or to not tear, hopefully prevent the tear. But you can also have the midwife or the provider do warm compress, and that can help too. Um, so putting a warm compress on the perineum when you're pushing can hopefully prevent some tearing. But really, it's just about easing out that head very slowly.
yeah,
That is going to prevent the tearing.
I
If you have
love
to be
that.
assisted, then you got to be assisted, and that's you're going to tear, but you're going to get a baby, so it's okay.
Yeah. Yeah. I love that though. I think that's such an important point because I don't think people talk about that enough. Like the final stage of pushing.
Yeah, that
Um,
is where the
I
tear is gonna be done.
yeah. I think that I loved how you explained that. I thought that was really great. Um, and just obviously something to keep in mind too for people because I think that's something like visually you explained that really well for people to understand. Like, okay, really try during this stage, like when you're feeling this. And I mean, I do think obviously depending on your provider, some it's so hard because I'm talking to so many women overseas, and a lot of the people that are supporting them are not speaking the language that they speak. So again, like this is why I want to do this and have these educational videos for people, and you explaining this for people is going to be so helpful because then hopefully these women are going into their labors and they're not so overwhelmed by everything that's happening and they kind of have an idea at least of maybe they just remember a few things, but as long as it's just a couple things where they don't feel like they're totally on their own with these the pushing stage and doing positioning changes and stuff like that. Okay, so let's talk a little bit about C-sections because this is another thing where I feel like the C-section rate is so high, and obviously it depends on the country and even on like the hospital that you're delivering in, and each provider their C-section rate's a little bit different. And I guess what in your experience, when are the times when you're like, okay, this C-section is totally indicated now, and like you'll say to your patients, like, how do you have that conversation where you're like, this is like we have to have a C-section at this point? And because I know obviously there's times when it's a complete emergency and you need to go in, like they need to do it very quickly. But then there's also C-sections where it's not an elective C-section, like they're not coming in for a C-section, but it's not quite an emergent C-section. And what does that look like where it's kind of that in between?
Yeah, so usually that is because they've stalled out to a certain point and the water has been broken for so long, they're not making progress and they've been unchanged for the past 4 checks. So in that situation, let's say the baby's doing totally fine, but the labor is just not progressing. Well, it used to be called failure to progress, and they took that, and now it's arrest of descent because nobody fails. So if you hear failure to progress, we're trying to move it to arrest of descent, but it's basically just failure of the body to progress to labor and or to the delivery. And at that point, I just tell the patient, like, we've been there, we've been unchanged, we've tried everything, like, it's been 12 hours. We've tried every position, we've tried every medicine, and there's a reason your baby is not coming down. It might be too big. There's so many different reasons. And I'll just tell the patient, like, at this point, we're at a risk for an infection, and then that could go to your baby. That could get you super sick. There's also a huge risk for hemorrhage after you've been laboring for so long, and maybe you've been on the Pitocin for, you know, 24 hours, and like that is just too long and your uterus is tired. We have to remember it's a muscle and it's not able to contract anymore. And so if it's just not in a good pattern, there are so many different reasons. But I try to just really explain to the patient, like, I hear that you want this. And we always say, I tell my patients, I hate the OR. Like, I don't want to go either, but there is a reason that we need to go now. And we don't want to just keep pushing this because your body's getting tired, your uterus is getting tired, you're at a risk for hemorrhage, you're at a risk for infection. Maybe the baby's so big and we could have a shoulder dystocia and that could cause a terrible outcome. So there's different reasons, and there's so many times where we say, this baby is telling us like it's not going to come out. And so I try to just see how many different ways I can explain that to the patient. If the patient's not stalled out, but their baby is not tolerating, then we call that fetal intolerance of labor. And that is sometimes maybe the baby has, cords wrapped around its neck. We've had babies delivered with 3 cords wrapped around its neck, and yes, it has a vaginal birth. That doesn't mean, it's not like, oh, well, my friend, had this and she didn't have to have a C-section. It's so dependent on your baby and the way they're tolerating it. So they might have a cord, they might have maybe their head's in a funny way or something is causing them not to tolerate the labor. And
Yeah.
yes, it's so frustrating, but it's like, don't we want a healthy baby out of this and not a stressed? We can push these babies so far. And unfortunately, sometimes we do, and they end up in the NICU and they have consequences to their labor. And I think
Mhm.
that's because we as like women strive for this perfect labor, and we forget that there's a human being inside that's going through all this stress. So if you can try to like put away your fear of the C-section and your fear of like, oh my God, I didn't get to do this unmedicated and all that, and just remember that we're really trying to work for the baby, um,
Yeah.
then I think that's so important. But I think a lot of times we get caught up in this like labor plan, and I don't want a C-section, I don't want Pitocin, I don't want that. And then we forget we're like sacrificing the baby for that. And so we just have to remind the patient, like, I didn't come into work today saying, oh, let's go to a C-section. I'm not trying to have this for you. But at this point, your body or this baby or whatever. And if she's getting sick, then I can be even more stern and be like, okay, you are sick. Like, we have to end this.
Yeah.
And let's get a healthy baby out of this. And then let's start recovering you. So
Mhm.
there's a bunch of different reasons, but I think I'm just like super honest with them. And I tell them, like, I do not want to go. This is not going to make my job easier. It's not like I'm just wanting to get you done with, or I think some people are like, oh, you just want to, be done with this. It's like, we need to go because of these reasons. Either it's you're at risk, your baby's at risk, or both.
Yeah.
And just trying to really explain that to them. And I think we've had patients that are like, no, no, thank you. And then like 30 minutes later, they call us and they're like, okay, I'm ready. And it's like, okay, I think you actually understood like this is dangerous or whatever.
Yeah. Yeah. That makes sense. And then kind of going off of that, for a patient that's coming back in trying to have a vaginal after they've had a C-section, does that labor look different? Or are you kind of just treating them just like a normal vaginal delivery, or is it different when they've had a C-section previously?
I'd like to say I treat them the exact same, but I think that's a lie because one, we can't use the side attack. So we don't have that cervical ripening agent, which is really always a bummer to me. But there's nothing we can do about that. But I do recommend epidurals to these women earlier than I do another labor. And that's because whether they like it or not, they're at high risk for another C-section. And I think it just
Mhm.
helps be prepared. It's not like I admit them and say, do you want your epidural right now? Like I let them go through it. But then once we're active labor and if they're thinking about it or and they can do an unmedicated, trial of labor after C-section if they want. But I do tell them like this will help us. That way, if we do need to go to a C-section, it's such a smooth transition. Going to a C-section from an unmedicated birth, if it's an emergency, can be very traumatic because they have to go under general
Yeah.
anesthesia. You're not awake for your delivery. You can't have your partner in the room with you. So there's a
Mhm.
lot of reasons. So for that, I do treat them differently because I put the epidural in their ear very early on. They do have
Okay.
to be consented at our hospital by anesthesia and the doctors, no matter what. So if they're with the midwives and they're doing a
Mhm.
Tolak, um, they are consented by the doctors at admission because we
Yeah.
want to know about them and all that kind of thing. So
Mhm.
they are treated differently in that way as well. Um,
Yeah.
but I think we're just more cautious with them. It depends. Did you have your first C-section because your baby was breech, or did you have your first C-section because you had an arrest of descent? To me,
Mhm.
those are totally different patients. So somebody that
Yeah.
had a breech patient or a breech baby and they didn't even get to try, I'm much more optimistic about their labor. Whereas if they had an arrested descent and then they said, "Oh yeah, I had this 10 pound 10 pound baby and I'm gonna try again," I'm like, oh, okay, might have another 10-pounder in there. So there's a bunch of different factors to take into
Mhm.
consideration. Did your first labor, did you try all the different moves? Was it in a different country where, a lot of places like Mexico, for instance, they always, I feel like, have a C-section. That's not true, but
Oh yeah.
they have C-sections all the time. And so we say, why do you have a C-section? And in Mexico, as an example, if they rupture the water and there's meconium, they will go to a C-section for that. We
Mhm.
definitely do
Okay.
not do that in the United States. And
Mhm.
so there's different reasons. And so really figuring out what this patient came from or what happened in there. Maybe they had an infection or whatever that maybe won't happen this time.
Yeah.
There's different reasons and different ways that you treat your patient based off of why they had their prior C-section.
Yeah. That totally makes sense. I mean, that was like I feel like my experience personally was kind of that. It was like, okay, I felt like, things happened in the C-section that maybe I was not given a proper, labor. And so I felt confident in trying for a vaginal delivery the second time around. But yeah, like you're saying, I did have to get, like, I saw the doctor, I think even before I went even into the hospital. I think when I was, because I was with midwives, and I think I had to meet with a doctor beforehand one time just to like talk everything through, make sure I was a good candidate and everything. And I did have some differences. I had to labor on a different floor. Like I wanted to be on the natural birthing floor, but I had to
Yeah.
be on the medical birthing floor or whatever.
Yeah, we're
Um,
all the same floor on our unit, but I do know there's some places that even have like a little detached like birth center and that kind of thing. Like
yes.
you probably won't be able to go to those.
Yeah. So that was kind of my experience, but I do know that they were working for like working to change that because it was kind of strange. It was literally like one floor difference. So it was
Yeah,
like, what, why does this really matter?
probably where their operating room is.
But yeah, she was like, my midwife was just so like, she was just funny about it. She was like, I don't understand why we can't just do it on this floor. But I think they were trying to work to change that. But yeah, I think, but I don't know. Personally, I didn't feel like they treated me any differently. Maybe it was because I was with midwives, and actually the midwife that I had a VBAC herself, so she had like personally experienced it. Um,
Yeah, I don't think you
but
should, as a patient, necessarily feel any different. I think that your
yeah,
nurse and providers and teams probably are treating you different in their head and their way of like going through your medical plan and like the,
yeah.
you know, different things that they're thinking about, but you shouldn't feel different as a patient.
Do you think that are you guys working on, I guess, on your floor? Are you trying to figure out like what's going on with the C-section rate at all? Because I just am seeing, obviously, like I'm in my research, like seeing trends that are going upwards in most countries, I would say.
Mhm.
Are you guys looking at that at all and like trying to figure out ways that you can kind of like bring that number down?
Yeah, we do have that girl that's doing that research on the balls, the different labor balls and all that, and I think that that
Mhm.
is something that she wants to look at and see if that, like, lowers our C-sections, rates.
Yeah.
But just right off the bat, not something that I know this is not research or anything, but when you
Yeah.
say that, something that comes to mind is we're just delivering much sicker patients nowadays. So the
Yeah.
people that are having babies are people that could not have babies in the past, or they're coming
Interesting.
there's people that are not taking care of themselves and they're coming in and they are so sick. They are so unstable for themselves and then they're going and getting pregnant. And so I think part of that, and that is not to speak for the C-section rates should not be entirely increasing like they are. So there's a
Yeah.
lot to be done about that. But I think a little bit of it to just think about is that people are having babies that are much sicker. And there's people speaking all the way back to my mom, where if I tell her, "Oh, that person had a baby," she's like, "Oh my god, they would have never gotten pregnant back, in the '80s or whatever." And there's just so much advancement, and people are choosing to get pregnant
Yeah.
despite their, and not to say that they shouldn't, but they're
Mhm.
just they're we're seeing much sicker patients than I think we have in the past, and so those are sicker babies, and those are usually babies that need to come out by C-section, not always, but that
Yeah.
might be a little bit of a factor that's playing a role.
That's interesting. That's really interesting. Yeah, I mean, that's one thing that I'm just like so like not fascinated by. That's not the right word, but I just am very I would love to eventually like look into just doing research on that because I think like even talking to the girls overseas and when I have clients that are delivering over here and they run into these things where it's like, their doctor's kind of pushing them towards a C-section. We're like, let's look at the C-section rate in this country. And it's like, some of these countries it's 50% or more. And you're
Mhm.
like, okay, well, this might be why, and
I think you're
sometimes
doing your part because if you educate people, then it will lower C-section rates because people, yeah,
yeah.
don't know. And there are places that I've heard of where it's like, oh, my doctor, had a meeting. I think like they had to get to it, so I didn't progress in
Yeah.
time. And I'm like, oh my god.
Yeah.
So I do think that that definitely happens, and so just educating patients of how much they can advocate for themselves. It's really
Yeah.
hard because it's such a fine line. Like
Yes.
advocate for yourself, but then when you're wrong, like shut up and
Yeah. Yeah.
listen.
Yeah. Yeah.
So yeah.
Yeah. No, I think that's exactly right. Like I try, I mean, because I went to nursing school, obviously I have like that background. I do try to like kind of teeter the line a little bit. And I'm not like I don't know, I wouldn't consider myself, I guess, like a typical doula. Like I'm not like super like holistic and like I like that side of it, but I also understand the nursing aspect and the medical side. So I think I try to kind of show both sides, I guess, with my clients personally, just because I think it's important to understand both sides of it. Um, so this is kind of a hard topic to talk about, but obviously there are times when families experience loss or they're going into the hospital knowing that their baby's not going to survive past, even maybe not even surviving at birth. I guess how do you go about supporting those families, and can you give any advice to people that this is happening to?
Yeah, I don't think I have advice for them because I've never been in their shoes. But
No.
I think that there's ways that they can navigate this difficult time. However, probably once they're in that position, they're not really thinking of like, oh, how can I best do this? So I
Yeah.
feel like if this was something for a nurse to listen to, I'd be like, oh, well, this is what you should do, and this is
Yeah.
how you should help your patients. So I think it really depends on the healthcare providers and how they're able to support that patient. As a
Mhm.
patient, the best thing I could say is state your wishes at the beginning and also know that hopefully your providers and healthcare team are not trying to be offensive, but there are times when we come in and ask certain wishes and desires. And I think the patient's like, I told the past 5 people that have come in here the same thing, like, "Are you guys not talking to each other?" Whatever. And sometimes
Yeah.
we're not, and that is a fault, but that's kind of the way that the system works, and so I will tell my
Mhm.
patients, like, "I'm so sorry that we have to go through these questions, and if this is not a good time, we can always go through them another time. If somebody
Yeah.
comes in right after me and asks the same questions, you can say, you can repeat them if you'd like, or just say, I don't want to go through this right now, or whatever. So if I'm admitting my patient, we do have a list of questions that we'll ask. And I say, some of these are pretty abrupt and uncomfortable. If this is
Mhm.
not the right time for you, say that. And I think that can be really difficult, but you can say, I can't talk about that right now. I don't want to talk about that. Or this is what I want and this is what I've talked about. Don't ask me again. But we will sometimes check in, especially if there's something like, do you want mementos to go home with? What can we do to support you after the fact? If somebody says, I don't want any mementos, I don't want any resources, nothing, you can bet we're going to check in again and say,
Yeah.
do you want the resources? And I know that can be frustrating, but we just really want to make sure that those patients don't get lost after and that kind of thing. And so
Yeah.
I think that that can be difficult, but also just stating, do you want us to refer to the baby? Do you have a name that you've picked
Mhm.
out and you want it? You know, are you like, can we please call the baby this? Ask us and or tell us, I guess, and then we should do that to kind of help and to respect the baby. Other
Mm.
people are please refer to this as a fetus. I want to move forward and I don't want to like, I'm just trying to get through this myself and just leave
Yeah.
this in the past and that's okay too. And we're not
Yeah.
going to judge whether you want to be calling this baby this beloved name or if it's a fetus to you.
Yeah.
So just knowing that you have those preferences and telling us
Mhm.
how we refer to things. Do you want us to some people don't want to call it a delivery. Other people just say, can you just not talk about the delivery of the baby? It's just like, so it can be difficult and just know that your healthcare provider is doing their best because it is hard
Yeah.
to switch from going from a room with a live birth to this situation, but you respect or like you deserve the care to be respected in that way. So if you are feeling like your nurse is not respecting you and not treating you the way that you need, you could ask for another nurse or
Yeah.
that kind of thing because you deserve to be respected in that difficult time. But there are a bunch of resources, probably at almost all hospitals, unless it's like a rural place. And so there's a lot of resources that you can have access to. And
Mhm.
there's like at our hospital, we have a perinatal loss coordinator, people that will follow up with you after, people that can get support groups. So I would say if you are somebody that is willing and wanting that, to really take advantage, get all the information, put it in your folder. You don't have to look at it, take it home, and then you can always dive into that, a week later when you're processing and you're really not doing so well and you want to reach out and use those resources. Just get it. And we'll give people a card and say, you know what, you can call her. And so in a week later, you just call and say, I'm ready now for these resources or things like that.
Yeah.
So you don't always have to be ready to make these decisions. And so just kind of go at your pace, I guess, and just
Yeah.
try to state that your wishes if you have them.
Yeah, I think that's great advice. And I mean, obviously, yeah, it's that I don't think that people talk about this enough. And obviously it's such a difficult topic to even think about because you don't want to think about like your baby not surviving, but I do think, obviously there are times when it happens. And so just kind of knowing that there are resources and things that like your nurses can do for you in the hospital to help you remember, or if you don't want to, obviously too, but like you're saying, just having your preferences for that and knowing that there's resources that can help you. I think it's just important for people to keep in mind, like because some people are going through this and they might feel like isolated and alone and not know what to do or who to reach out to or what they can ask for and stuff. So I think it's just good to know that there are those resources out there for them.
Yeah,
Um,
and just knowing that, like, your baby can stay with you. So sometimes people say, like, "Where are you gonna take him or her?" And my answer is always like, "The baby can stay with you as until you leave the hospital." So some
yeah,
people want us to give them time for like an hour and then say their goodbyes. Other people will keep the baby with them until they leave the hospital. And I can offer, um, do you want me to take the baby before you leave, or do you want to leave? Some people find comfort and, do you want to leave the baby in this bassinet in your room? And then you guys can leave and then I'll take care of everything afterwards. So just like thinking, like, always don't be afraid to ask because we just might say
yeah,
no. But there's different ways that we can kind of help the whole process because none of it is natural.
yeah. No, it's so true. Yeah, I think that I mean, obviously people are very lucky to have your support, like as a nurse and any other nurse that's supporting someone through that, because you're obviously experiencing it too, and um, in a different way, obviously. But like you said, like you're trying to do the best you can to support these people, and so I think it's great that they have that support. But yeah, knowing that they have other resources and things that they can look into to try to help them navigate that. So to wrap up, I would love for you to just maybe give a few things that you would say to a new mom that's um, going to experience birth for the first time. Just a couple pieces of advice that you would give them that you would say, like, make sure you are educating yourself on this, or I don't know, like just from your experience, moms coming into the hospital, if you were like, oh, I wish that they would have known this, or for you personally when you're going to be going through this someday, like what you are like, okay, I need to make sure I prepare myself in this way.
Yeah, I think it's just wrapping up everything we've already talked about. So just one, if you do have a partner that's going through this with you, having like you can't really make clear expectations because you don't know what's going to happen, but just explaining to them like this is where I want you to be, this is how I want to be supported. I want you to be involved, or I want you to stay over there and get away. Making sure that
Yeah.
you have like that support in the room because it is going to be an adventure that you have no idea what you're going to be going through. So just having what you know is going to make you comfortable. If that's um, a speaker and making a playlist, if that's going to have the music for you. I
Yeah.
think that's like, I love when my rooms have fun playlists and that kind of thing. I've
Yeah.
heard everything from like the cute little folky, really relaxing to like, I have delivered a baby to full party music, which was really interesting. But if that's what they want to do, then that's fine. It can be kind of weird, but that's okay. So just
Yeah.
kind of knowing how you're going to create your space to help you. I think setting yourself up. If you're delivering in a hospital and you didn't want to be in a hospital, that doesn't mean you can't have. You can get the little battery candles. You can get like aromatherapy, those kind of things. Like yes, you cannot have any flames or things like that, but not everything has to be shot down for your room environment. So I think
Yeah.
setting yourself up in that regard is important. And then um, this is what we talked about the whole time, but just advocating. And I think that is asking questions. So remembering not to take their word for it right off the bat, because when your doctor is going to come in and say, okay, hi, I'm Dr. So-and-so, this is what we're going to do. And
Yeah.
you can say, oh, is that the first step? Or was there something we could do before if I'm not ready for that? Which can be really uncomfortable. But I think that's just
Mhm.
like something that I tell all my friends is like, ask questions, ask to be moved, ask to do this. Like,
Yeah.
these people are there, and especially for your nurses, they're doing this every day. They're tired. A lot of us are burnt out right now, and I don't think every nurse is giving. I'm not giving 100% every single shift, but when a patient stops and says like, "Hey, this is really important to me. Like, this is my goals for today is like to move or whatever," I'm gonna listen to that and be like, "Okay, you know what? This is what is needed." So just kind of remembering to ask questions, advocate, and then lastly, go with the flow, because um, that you can have your birth plan, and that might be helpful for you, especially if you're type A and you need to have that typed out. But and you can give that to us. That's totally fine. And when I receive a birth plan, I say this all looks really great, and then I will sometimes say this bullet point really seems like something I'm not going to be able to help you with today. Like, I do not think we're going to be able to do that. And just going through that to kind of set expectations from the front or beginning, and just know that that's not because they don't respect you or they're not going to help you. It's just we're trying to set realistic expectations. So then just know that maybe your birth plan is not going to work out, and that's okay. But
Yeah.
you're going to get a baby at the end of it, and so we need to focus on the end goal.
Yeah.
But that's
Um,
it.
I love that. Okay, quickly, actually, that kind of reminded me. So for like a birth plan, do you actually as a nurse? Like, I know a lot of people are like, oh, nurses aren't even going to read this or
I love
whatever.
to read them. I love to read them. I find them hilarious sometimes, but I love to read them because sometimes they are kind of comical.
Mm.
And I think that that's not to be rude, but sometimes I'll even tell my patient, like, I'll be like, oh my God, just the other day I had one and I told her, I was like, this made me laugh. Because I will say, like, this point is not how, like, this is going to lead you to feeling like failure. So you said you wanted this, and that's just really not something that we're going to be able to do. That
Mm.
would be somebody that like is toe walking and they say, I really want to start with side attack. You cannot in a hospital. So I see this bullet point. That's not going to happen for you today. I want to address that right now. Blah, blah,
Yeah.
blah. One time we had somebody write on it, if my partner annoys me, I'm going to say the word pineapple. I was like, okay. So if there's some like secret word you want or something like that, those are funny and that works. But yeah, so I think that we're gonna read it and your provider is gonna read it and people are gonna read it. The thing that is hard is when people have a distrust in the healthcare system, and a lot of times that is for good reason. Maybe they've had a bad outcome or something like that. And we do
Mhm.
have people that come with birth plans that are signed by lawyers that show what they're
Wow.
going to do or kind of accuse us and say, if you neglect me, this is what's going to happen. Or if you give me Pitocin, you are neglecting my rights, blah, blah, blah. Those are very aggressive and they are not going to set you up for success. I think if you want to have like a document in the back that makes you feel comfortable with your lawyer because
Yeah.
you have that distrust, that's okay. But presenting that to your healthcare team that is there to help you is right off the bat saying, I don't trust you and I'm going to sue you if you do anything to me. Kind of
Yeah.
sets the tone um, a little difficult. So there's a whole range of birth plans, but I would just
Yeah.
say it's okay. And you should make one and just so that you can at least start a conversation. But just
Yeah.
knowing the tone of your
Sure.
birth plan can kind of, you don't really want to attack someone right before they're about to care for you throughout the whole day. So
Yeah.
just be cautious of how things are portrayed.
Yeah. No, I do. The pineapple one. I can't stop thinking about that. I'm putting that on my next one. Oh
I
my
was like, oh,
gosh.
do you want pineapple right now or are you in pain?
Oh my gosh. I mean, I've heard of people doing it for like for if they don't want an epidural or whatever, and then they say like, okay, if I say this
Yes,
word,
yes.
then I need an epidural. But I'm gonna use that next time for Kevin. I'm gonna say if you're annoying me during labor, I'm gonna
I
say
need
pineapple.
pineapple.
That is so funny. So yeah, I do. I like to kind of refer to them as like, I always say to my clients, like, I don't really like calling it a birth plan because labor is just so unpredictable and you just really don't know what's going to happen. So I like to say like your birth preferences, like, hey, this is what I would love to happen, but maybe this is going to happen. Maybe it's not. Um, so yeah, but I do. Yeah. I think I try to get them to try to get my clients to get it down to like one page. So it's easy for nurses
Yeah.
to just kind of
Yeah.
like glance at.
I think
Um,
that's really helpful. Yeah.
but yeah, so I love that. Okay, well, thank you so much for
You're
coming on,
so
and
welcome.
I'm so excited to share this with everyone because it's going to be so helpful. Like I just after talking to all these women, I mean, just having the perspective of a nurse, I think is just going to be so helpful for people, and like knowing these different terms and hearing them kind of, in a way that they can understand because so many women just have no idea about inductions and epidurals and what these things look like in the hospital and peanut balls and what to ask for and all these things. So I'm just so excited for people to listen to this. I think it's going to be so helpful.
Yes, you're helping so many people.
So excited. Okay. Well, thank you.
Okay, love you. Goodbye.